So I'm going to begin with Mark to tell us what he thinks the main themes are and what messages, 2 or 3, that we ought to take out of the papers before us. Mark.
Thank you, Sheila, and thank you for the opportunity to be here. I want to thank NAS for not only including me in this panel and including patients, family caregivers, patient advocates throughout the process here as authors and participants, but to really think through what has often been a missing link. When I think of the theme that is most important when I look through these papers, it's the theme of the concept of patient centricity and how it's beginning to mature. Patient centricity is something we've been talking about for a long time. And I run into experts all the time who say, I put the patient first in everything I do. I think about them, and I look to do what is best for them in all my activities. That is not patient centricity. That is paternalism. And that has characterized our healthcare system for many, many decades. Patient centricity is more than thinking about what's important to the patient and their family caregivers. It's about engaging them, understanding what's important to them, looking for the cues that go beyond simple health. It's understanding their information and then utilizing that information to design and deliver health. That is very different than having good intentions. And I don't deny for a moment that everybody I have dealt with in health has really good intentions. But I became a patient advocate more than 25 years ago because I saw so many people in my family stricken with chronic disease and disability. I watched them deal with autoimmune, neurologic, cancer, autoimmune, rare. I watched a lot of them deal without effective treatments, and I watched a lot of them deal with a delivery system that was not aligned with what was important to them. And I watched most of them die over a relatively short period of time. And I've devoted my professional advocacy career to ensure that we truly and meaningfully, in a scientific, reliable, representative way, engage the end user in how we design and deliver care and how we develop new treatments. When you look across the papers, there are elements of this throughout. And I've seen a huge evolution in just the last decade. And I want to describe it in the context we use in the patient community and then highlight one area that I think is missing or not well addressed in the papers. We in the patient community think of this in what we call the chronic care trifecta. So I'm curious in the audience, how many people know what a trifecta is? I see a few hands. I always get a kick out of asking that question because people are a little reluctant to raise their hands. A trifecta means you pick the top 3 horses in the right order, and if you do that, you win big at the horse races. I'm here to tell you from the perspective of people with chronic conditions, 133 million of them in the United States, and a subset of that population is driving the vast majority of costs in our delivery system. View this in 3 discrete parts. We want to have treatments that are safe and efficacious. That's a given. But that's only a part of what we want. We're looking for treatments that are going to work, but they have to work in the context of where we are. And that's where the social determinants of health, behavioral issues, and the environment play a huge role. We live our lives in a context. Once we're diagnosed with one or more chronic diseases, we're not just a disease. We're not something just to treat. You have to come at us and deal with us in the context you find us. And you see a lot of references to that throughout the papers. So having a clinically effective treatment delivered in the context that you find us, given all the different determinants that are impacting our daily lives, critically important. But there's a third part to get the trifecta right for these complex, high-touch, high-cost patients. And that is, you have to understand what their goals are. If you forget about what they're trying to achieve and treat them as a disease, you may very well be throwing a lot of money, a lot of good care that is clinically sound, but completely irrelevant to what's important to that patient. And I want to drive it home by giving you a couple of very quick examples. Think of two people with Parkinson's, and imagine that they're expressing the disease in the same way, which rarely happens given the variety and challenges with that disease. But imagine it is, and they both go into the medical system and they get the best care and they get the standard of care. That might be completely irrelevant to what's important to them. Imagine one of those gentlemen is concerned about keeping their partner awake at night due to the tremors and wants to be able to sleep without causing disruption to that family unit. Imagine the other person is up for a promotion and doesn't want his or her employer to know that they have a disease. Knowing those goals would allow you to tailor a treatment for each of them that would be different, not standard of care. And yet we rarely ask people who are high-touch, complex patients what their goals are. From our perspective, to get the chronic care trifecta right, it's provide good, sound medicine in the context of where we are, our personal circumstances, but it has to be relevant and aligned with our goals. One other quick example is a real story of a woman in Baltimore who had diabetes and heart disease. She was being treated and given absolutely the first-class care. And yet, she wasn't being compliant, she wasn't being adherent, she'd be scolded every time she went into the doctor's office. Nobody took the time to figure out what was important to her. Turned out she was a single mom with two children, one in high school, one in college. She was living to make sure her two daughters did not become single mothers like her without an education. And she was going to do everything in her power to make sure they got good educations and did well. The treatment regimen she was on made her lightheaded and dizzy, and you might say, well, you know what, it was still the best care for her. The reality was she drove a bus. There was no way she could be compliant or adherent under those circumstances and meet what were her priorities in life. Designing care around the individual with what is most clinically effective relative to their personal circumstances in the context of their goals. And that's the piece I didn't see enough in the papers. But I will tell you, I've seen a huge maturation in the concept of patient centricity, moving from good intentions to let's figure out how to engage patients in a meaningful way to understand what's important to them. Because at the end of the day, these high-touch patients that are driving costs are utilizing the system to meet their goals. They're not utilizing the system to get good blood sugar ratings. They're using the system to achieve their goals. I'll stop there.